I'm Dwayne Schultes, and today on this Vital Health podcast, we're discussing the challenges of antimicrobial resistance and what needs to be done to avoid a looming potential public health crisis. I'm very pleased to be joined today by Henry Skinner, the CEO of the AMR Action Fund. Henry, how you doing?
I'm doing well, Dwayne. Thank you, and thank you for inviting me.
It's our pleasure, and thank you for being here. I'm also joined today by my colleague, Joe Hemming, VT's U.S. Business Director and a card-carrying neuroscientist. Joe, how you doing?
Great, Dwayne. Thank you very much. Good to see you. Good to be here.
I understand you're recovering from a bout of COVID. How's that going?
I'm 75%.
Joe, I think we may have caught it together. I had a bout last week.
Did you?
It didn't hit me too hard. It was nice, and then it kept me from traveling the following week. So there's upsides.
Still a good excuse. Henry, can you tell us a little bit about the AMR Action Fund? What is it and what do you do?
Absolutely. So the AMR Action Fund came about through an interaction of the Wellcome Trust, which is a philanthropic organization in the United Kingdom that focuses on a number of public health issues around the world, the World Health Organization, or WHO, and a number of pharmaceutical companies who 6 or 7 years ago were looking at the diminishing pipeline for new antibiotics and came to the realization that the market was deeply troubled and that the biotechnology industry, which does so much of the innovation around healthcare and so many different things from pharmaceuticals to devices to diagnostics and beyond, really was not delivering a robust pipeline of new antibiotics. And yet we need them, and we'll get into why that is. And so realizing this, the Wellcome Trust, WHO, and the pharmaceutical companies considered that the key reason that we don't have a robust pipeline is a lack of financing, which is due to a number of things, market failure, some challenges in the sector specifically. And so they came together to form the AMR Action Fund about 5 years ago, sought partners, and ultimately have about $1 billion committed to financing innovation to develop new antibiotics. We invest in biotechnology companies that are private, small companies typically. We invest in clinical stage companies, so those companies that are testing their products in human clinical trials to demonstrate that they're both safe and effective in treating drug-resistant infections.
So you've worked in the venture side, and you've worked for large pharma, Takeda. You've been the managing director of the Novartis Venture Fund, which is an early stage fund. Obviously, you've been brought in to look at developing these companies, make strategic investments in AMR. What motivated you to take this role?
It really comes down to trying to use my experience and my education and to do good. I've been very blessed in my career. I trained as a microbiologist. I've worked in small companies and large companies. I've run a couple of biotech companies. And all of that is special. All of that clearly was focused on patient need. What can we do to improve health? But one of the greatest medicines we've ever created is antibiotics. If we turn back the clock, and there's not many of us around that will remember the pre-antibiotic era, certainly no one on this call, and my parents were born.
Although we may be pushing it, Henry, but yeah.
Well, we may be getting back to it. But 3 or 4 of the top 10 causes of death prior to antibiotics were simple infections.
Yeah.
It killed huge numbers of people, lots of young people. It really made surgery extremely risky. Dental work could kill you, right? Walking in the garden could kill you. There are sons of presidents who were playing tennis who got a simple infection through a blister in the toe that died 2 weeks later. Infection was an extremely risky thing. And the advent of antibiotics discovered in 1928, or even some crude ones earlier, really took off after World War II, as we had a Manhattan-like project to actually produce penicillin. It meant that these top killers disappeared from the top of the list and became extremely rare. That, with vaccination, probably have added 15, maybe 20 years to life expectancy from going back to the 1930s to today. So just a huge advancement in public health, and has gone around the world to save hundreds of millions of people. And the beauty of these drugs is that you use them for a week, maybe 2 weeks, maybe less, and you've saved somebody's life. Unlike a lot of other medicines where we have treatments for chronic illnesses, the beauty of these is we cure the underlying pathology and we live a robust, healthy life. And that has just added decades of healthy living to humanity, which really was the attraction. The challenge is that when we use antibiotics, bacteria who've been evolving to fight each other in the environment for billions of years. As long as there's been life on Earth, they've been fighting with each other. As we use antibiotics, the pathogens develop tools that they can become resistant to them. So that antibiotic that worked yesterday or in 1950 doesn't always work today. And when it doesn't work, well, we need a new one. And that's really the underlying challenge here.
Joe, Henry's discussed a lot of the key market issues and the reasons why antibiotics are so important. Obviously, we've seen a huge need emerge to have effective antibiotics. They're not coming to market. There's been a big problem there. Joe, what makes AMR such a difficult problem from a public policy perspective? What is driving the challenge?
From our perspective, when you think about developing these drugs that are used for very short periods of time, as Henry said, maybe a week, 10 days, in most cases when these treatments are successful, that is a very short time for research and manufacturers to recoup their expense. When you look at it, the cost of the drugs becomes very high as a result. There's a lack of understanding that if you don't have the ability to use these drugs as often as we need to, then we have this growing problem, lack of understanding of how these drugs are developed. From an R&D standpoint, I think there's also another major issue. These drugs are essentially the only class of drugs that lose effectiveness through their use. When you think about generic drugs, whether they're antihistamines or cardiovascular drugs, these drugs, they become generics and they're essentially free. And this is certainly not the case with antibiotics. This is accelerating because bacteria continue to fight. They reproduce very, very, very quickly. The public health standpoint, it is very hard for many policymakers to really understand the immense challenges for developing these products.
We have a link, and I always pull it up when we're dealing with AMR, and I can grab it at any time. It's current FDA clinical trials filtered to antimicrobial resistance. And if you click on that link, I guarantee at any time there are more than 3,000 ongoing clinical trials. So the question it doesn't seem to be a question of pipeline, it seems to be a question of market. Henry, on that, the AMR Action Fund is supporting some very important research aimed at better understanding the link between certain areas. We see an emerging need, particularly with sepsis related to cancer treatment. Can you tell us a bit about that work and that publication and some of the findings?
Absolutely. I think when we're going through treatment, we're very vulnerable. We're given very powerful drugs that just makes us susceptible to viral infections, bacterial infections, fungal infections, stress. The data of how much risk there was and the consequences just isn't robust. And part of that is, I think, natural, right? If we have a friend with cancer who becomes ill and enters the hospital, it's a horrible thing, and we say their cancer's really been difficult and they're fighting it. Well, they may be fighting an infection.
Yeah.
Cancer is certainly an underlying comorbidity that made them vulnerable. But they're not in the hospital because the cancer is killing them. They're in the hospital because they have an infection that's killing them. So we sponsored a study and did some work to really try to understand what is the risk, the particular risk in cancer for patients that are both inpatient and outpatient. So when you're in the cancer hospital undergoing surgery and aggressive therapy, when you're in an outpatient setting, maybe getting a weekly infusion of your chemotherapy, that might go on for 6 months or a year or longer to manage your underlying cancer. What is the risk from infection? What is the risk of drug-resistant infection, which is more risky, harder to treat, more lethal? And the data is striking. Cancer patients who we know are vulnerable to infection get more infections and scarily get more drug-resistant infections. And that ranges across the pathogens. It can be 1.5 times the risk to as much as 5 times for some pathogens. And so not only are cancer patients vulnerable, but they have greater exposure and certainly more significant consequences of getting these infections, much more difficult to treat when your immune system isn't robust as it is when we're young and healthy. So the data is clear. Cancer patients are more vulnerable, they get more infections, and they get substantially more drug-resistant infections. So the consequence on cancer patients is dramatic. And fundamentally, while we think that we're making huge strides in treating cancer, and we are, every time someone who's going through a cancer therapy dies from an infection, we've lost an opportunity to benefit from the billions of dollars of investment in our anti-cancer approaches and enabling our oncologists to treat patients. We need to remember that we need to think of the patient as a person holistically, and treat everything that they're going through and make sure that they have every possible chance to make it through their chemotherapy and receive those benefits.
Joe, coming back to you, Henry's outlined a key medical need for new antibiotics. We've discussed the problem that we have a lot of early stage clinical research that's going on that doesn't progress to phase 2 and phase 3. Obviously, the AMR Action Fund is trying to correct that. From your perspective, where is that gap emerging? Why is there such a lack of our ability to bring and target new drugs for something like sepsis related to cancer treatment? Why are we having this problem?
First of all, the number of companies that are involved in antibiotic research today is greatly diminished from the last few decades. There has been a brain drain from antibiotic development. That's one issue. The other is, of course, it's an opportunity cost. If you're a large pharma and you're involved in antibiotic research as one part of the R&D pipeline, you have to look at this and make choices. The hundreds of millions of dollars or the $1 billion that's spent on an antibiotic development program is money that isn't spent on something like obesity or cardiovascular disease or others where there's a much greater opportunity to recoup the R&D investment. So they have a fiduciary responsibility to investors, of course, to develop drugs that do recoup their investment. That doesn't mean that there aren't many companies, small and large, that continue to do this work, but there have been many fewer. If you look back to the 90s, there are probably 20 or so companies that are working on developing antibiotics. Today, that number, as far as the larger firms, is probably 5 or so. That's a huge difference. It's just that simple. The other thing, of course, is this science is very difficult. There's no question. It's these bacteria that we're facing have the benefit of hundreds of millions and billions of years of evolution. The science is difficult. There are regulatory issues I think we could probably talk about.
Yeah.
And then at the end of the day, you are faced with marketing and selling a drug that is only used for a few days, a week, 10 days. All of that wrapped together makes this a very difficult area of drug development.
Henry, Joe's laid out some of the challenges from a commercial development side. One of the core focuses of the AMR Action Fund is challenging how society values antibiotics, addressing this issue from a policy perspective and trying to change the scope for the market conditions. Can you walk us through those economic challenges from your perspective at the AMR Action Fund, but also how you're trying to change the way people think about it?
We need to understand the world we live in. And from the world we live in, from the pharmaceutical market standpoint, has been highly successful for many decades and driven enormous benefit to our health. And in return, we're going to give them a little bit of time where they have a legal monopoly and they can make a return on that investment. And this has proven to be enormously successful. Antibiotics, on the other hand, as Joe said, we use them for a week, maybe 2 weeks. So the time that we're selling the drug is very low. The latest ones we want to not overuse, because the more we use them, the more resistance there is. So we have a public health demand that we not use the drug for everyone who would benefit, because some of us would benefit from that cheap generic drug, penicillin from the 1950s, and that's fantastic. But what it means for someone who develops a new antibiotic, we put it behind glass and say only use in an emergency. So the volume of use is very, very low. And yet it can cost $1 billion or more to develop a new drug and take a decade of research. And that's just the direct cost. And most programs that start to develop a drug fail along the way. So there's an enormous amount of failure that has to be factored in. So that means that the market just isn't there, although the expense to develop the drugs is still extreme. Because of the way our system works, we can't get the full value there. if we appreciate the value of antibiotics in enabling basic health care, things like hip transplants that offer enormous quality of life improvement, these surgeries are impossible without antibiotics. And what this becomes effectively is a tragedy of the commons. How do we draw light to these other value dimensions that clearly are there, just as the value of reducing carbon dioxide or methane in the atmosphere clearly has a benefit to society in the long run. Antibiotics are the same thing. And like all tragedy of the commons, the market system can't solve the problem. It requires government intervention so that we recognize the full value proposition within a means of creating the right incentives to ensure that we maintain the quality of that public good. And so really, it's a question of trying to help policymakers understand these other dimensions, which we don't often think about, and how to create policies that align with it. The United Kingdom has done some remarkable economic modeling of these things called STEADY, which looks to place a numerical value on each of these incremental things that are clearly beneficial impacts of antibiotics and maintaining antibiotics. Through such economic tools, I think we've been able to put some numbers to that to say these are very valuable public goods. Not having them will have a huge direct and indirect consequence. And I'll just illustrate, even today, just for, I think, the top 5 drug-resistant pathogens, probably going back to about 2019, the data, cost the U.S. healthcare system $6 to $7 billion a year, just in trying to treat these drug-resistant infections in patients because they're difficult to treat.
Part of the problem when we look at this from the concept of the tragedy of the commons, the tragedy of commons was an issue of fiduciary responsibility and ownership, because essentially everyone had it and then no one had it. At the same time, no one had responsibility. And I think that's sort of an analogous situation to what we're finding with some of these very effective antibiotics like penicillin. The reality is it works most of the time and it's free. The opportunity cost of switching becomes very high. I was moderating a panel at Gastein, the big public health conference in Austria, back in 2014, 2015. And Chris Hoyle, an economist from AstraZeneca, was on the stage, on the dais with me. And we had a question from the audience. They said, hey, what about AMR? How do we deal with AMR? I'd remembered that AstraZeneca had just put out a new multi-spectrum antibiotic. And I spun on my heels and said, hey, wait a minute, Chris, you guys just released one, didn't you? And he sort of sheepishly says, yeah. I'm like, how's it going? He's like, well, I'm not going to give you total commercial numbers, but I can say this. In Scotland, we've sold 2. And that's the reality. That's the problem. There's such a big issue there for incentives. What do you do if you've spent $1 billion, $1.5 billion, $750 million, and you sell 2?
One of the interesting points that in policy conversations that we've had is the desire on the part of policymakers, as Henry said, break the glass and use it so that there are drugs in reserve. I'd like to talk to chip manufacturers or airplane firms and computer firms. How many are asked to put billions of dollars in R&D to develop a product that is put under glass and used only when actually needed? This defies logic. It just puts just an additional immense pressure on a company, on an industry to develop these products.
And Dwayne, your AstraZeneca example is very poignant, because I can tell you the consequence for AstraZeneca is that they left R&D for antibiotics, and they were one of the leading programs. And as you said, brought a molecule that was very much needed to the market to lose money on it, and to say we just can't keep doing this anymore. And these companies cannot lose money; they have to make money. Even nonprofits have to make money, or they go out of business. So we have to have a means of recognizing what the value proposition is and making sure that we have the right incentives to acknowledge it.
If we look at some of the incentives programs that have previously existed that have been passed, everyone made a big noise around the GAIN Act, which was passed a decade ago. Joe, has the GAIN Act worked? Has it done anything?
I don't know anyone who's going to say that GAIN was a huge win. In fact, it's quite the opposite. The incentives, the pull incentives, have not necessarily done much
So, Henry, we've had gain. There was Pasteur, which was supposed to provide an R&D incentive that ended up at one point having all the budget pulled out, and then it just sort of languished and went away. Coming out of COVID, are there some incentives that could work? What about warp speed for the COVID vaccines? Leaving aside some of the political hot button issues around that, the fact is it was very successful at getting assets forward. If we gave something that was a real incentive and a real guarantee of acquisition of product, would something like that work?
Yes and no. So Warp Speed was a fantastic program at a moment in time, and frankly quite bold for the time. But it benefited from decades of investment in entirely unproven technology, mRNA vaccines. Developing a new antibiotic, it cannot be done in under a year as Warp Speed delivered. It can take a decade or even more. It's just a much more complicated thing that takes a lot more time. And frankly, we don't want it to reach a crisis, right? The cost of the pandemic with COVID and the need for Project Warp Speed, what was shocking and cost huge amounts of suffering to humanity and deaths and so forth, we weren't prepared. We did not invest a little bit over time to stay ahead of things, to have the capability. And so it doesn't work. Now that said, clearly there are ways of designing incentives to solve this problem. It's twofold. We need to incentivize research and development, and we need to incentivize access. Simply getting the drug approved is a necessary step to giving patients benefit. We need these incentives to both drive innovation, and I think well designed to bring private investment back into this space so that we can have a robust pipeline, so we can have new approvals.
Picking up on what Joe was saying earlier about some of the research we're working on and some of the things we discussed at the bio panel, we're seeing an enormous tail, and it doesn't matter which group we're looking at, if it's the non-AMR group or the AMR group and the extraction of real-world evidence we're looking at. When we actually investigate the length of time of infection, we're seeing that there's very little differentiation when you get to these extreme outliers beyond the standard deviation. We're seeing tails going out 100, 150 days in AMR and non-AMR, and it doesn't matter just for sepsis. We're also seeing this in hospital-acquired pneumonia. It's ubiquitous across all the indications we're investigating. Now, this screams to me that we are not effectively using diagnostics. It seems to me that we're not applying a good, rigorous diagnostic because the populations don't separate. If you look at those that die and those that do not, they overlap for 14 days. You've got 2 weeks to actually make a determination, and we're not seeing any segmentation there in activity, at least not yet. We hope we do, but we're not. Joe, why are we avoiding diagnostics?
The problem is that they're costly. We know that many of these diagnostics need to be refined. We see this problem across medicine. The infectious disease area is not unique. We see this all over. It's a situation, as I've noted before, where patients are asked to fail on something that's inexpensive, generic, perhaps antibiotic. And these are decisions that are made whether by clinicians, whether by hospital systems, or whether by insurance. I think that's the biggest problem.
Henry, if we're talking 100 days at between $5,000 and $10,000 a day, that's an enormous market. That's an enormous cost. It seems like a cynical decision not to implement a diagnostic that may be $500 or $900, somewhere in that range. What's your perspective on this?
I completely agree. I think we have some powerful diagnostics. They're not perfect in a number of fronts, but we have a number of headwinds, right? Joe mentioned the first one. Let's just say it's a much more less expensive diagnostic, simple clinical microbiology. Maybe that's $50, $75, but that's a $50 or $75 cost to prescribe a $5 antibiotic. It rings odd, but the absence of use of that diagnostic leads to exactly what you said, these enormously expensive and long tails. You know, you've got a sick patient in front of you, you want to treat them, right? Physicians are predisposed to try to ameliorate the suffering of their patients. Some of these diagnostics take time. They take 2 or 3 days to culture the bacteria, if you can find it, and you can't always find it, and then do some of these next-gen sequencing or molecular diagnostic tests that might be your $500 or $900 tests, but are highly informed. So there's a time component. There's an access component. All of these things add complication. Frankly, you know, you've got some of these patients with comorbidities or immune compromise that need longer therapeutic interventions to benefit because their immune system just isn't as robust to help fight off these infections. You need to serially give a diagnostic to these patients to make sure that what you've been giving them that started to work hasn't lost effectiveness. Because we know if we use an antibiotic for 30 days, we will start to see resistance in patients. And that means we need to repeat these diagnostics, and there's a repeat cost. But if you're in the ICU for 150 days to $10,000 a day, this would seem to be a no-brainer. So all of these things conspire to make it very difficult. But the diagnostic field suffers many of the same economic problems of the antibacterial field, which is how do we really recognize the full value of these diagnostic tests and make sure that we're using them to maximize the benefit patients can gain.
We've talked about the cost of innovation. It's a very simple concept, in my view. If you're not using today's diagnostic tools, how are we going to expect the diagnostics makers to continue to pump hundreds of millions of dollars into products that aren't going to be reimbursed? They won't. We've had some very frightening conversations with diagnostics makers about their feeling about this area. They're making very difficult decisions about what they're going to push forward.
What about antimicrobial vaccination? I mean, there have been several platforms that have been very good against pneumococcal pneumonia, very successful, treating the elderly. Are we overlooking a tool in our toolbox?
As a grandparent and as a senior citizen, we feel blessed to have a pneumococcal vaccine. Any grandparent who visits their grandchildren, most of us would want to have that protection so that we're not passing anything on to our grandchildren or
vice versa.
Or vice versa.
They're little walking petri dishes, you know?
That's absolutely right. But the point is, how do we value that? You almost can't put a price on not getting sick, where many people my age would get sick in a setting like that.
The other thing about vaccines that we're just beginning to learn, a study recently came out of the use of the shingles vaccine of having a beneficial impact on Alzheimer's. I think we really need to think about vaccines much more holistically of all the benefits they have and continue to study them. But if that data continues to play out, the ability to actually move the needle on Alzheimer's through a vaccine to something like shingles is a just hugely phenomenal benefit that I think we should not turn a blind eye to.
Exactly.
Absolutely not. Henry, if you had the opportunity right now to propose one piece of legislation or one regulatory act, with this administration, it's a movable feast, I know, but if you were given the opportunity to make one recommendation between now and the midterms to help people understand AMR, what would you like to do?
First, time is critical. The pipeline is dangerously thin. We've been losing human talent, human capital to this problem now for well over a generation. We are not training the young people to come into this field. In fact, we're advising them to stay away because economically it doesn't make sense for them as individuals. We need to put meaningful market incentives in place that change the trajectory, that are market-based, in other words, that bring capital back in, smart capital, that knows how to build companies, knows how to drive innovation, and we need to simply start.
Joe, same question to you. What do you think?
I think that the economics of drug development is very poorly understood across the board. Why do medicines cost so much? Because it costs a tremendous amount to develop drugs. The failure rate in many areas is disastrous. Look at Alzheimer's disease. I think teaching, doing everything we can to explain to policymakers how difficult this area is the only way that there's going to be movement in this area.
Henry Skinner, CEO of the AMR Action Fund, thank you very much, sir. It's been great speaking to you.
Thank you, and thank you for inviting me.
The producer of the Vital Health Podcast is Dwayne Schultes. Our editor is Mark Brodeen. Our project manager is Caden Drake. The Vital Health Podcast is a production of Vital Transformation, LLC, copyright 2025.